Hey folks, my name is Dr. Amy Pearlman. I'm a board-certified urologist with expertise in sexual, hormonal, and genitourinary health. And welcome to today's episode of Pearls and Perspectives. I have Dr. Susan MacDonald here with us today. Susan, say hello to the crew.
Hi, everybody. I'm Susan MacDonald. I'm currently program director at Penn State. And I also did the same reconstructive fellowship as Dr. Pearlman with Dr. Terlecki at Wake Forest in male genital reconstruction.
Yeah, that's how we initially met, actually, several years back. So today we're going to focus on the newly released pelvic pain guidelines for men, the first time that the AUA has put out these guidelines. Does that sound like a reasonable topic for today, Susan?
I think it sounds like a great topic and a passion project of mine.
Awesome. So how did you segue from doing your GERS fellowship to developing this clinical interest in chronic orchialgia and male pelvic pain?
I know it's a bit wacky. Sometimes I still ask myself the same thing. But what happened was when I came to Penn State, I feel like when you take a job, it's a little bit like being a puzzle piece and you have these areas of expertise and they have these gaps that they need to fill. So I said, okay, I will take sexual medicine and I will take chronic orchialgia. So patients, I had learned to do spermatic cord denervation in fellowship. And then also voiding dysfunction because I was hoping to capture male BPH patients as well as stricture patients. The Venn diagram of chronic scrotal pain, sexual dysfunction, and voiding dysfunction, the little center of that is pelvic floor dysfunction in men. So for my first 3 to 4 years, I was seeing it everywhere. Now, the thing that makes it so quizzical is these patients come in as any one of those things. They can come in as erectile dysfunction, as chronic testicle pain, as urinary hesitancy or straining, weak stream, all that stuff. But then I had all these patients who were getting retrograde urethograms or cystoscopy, and it was stone cold normal, but complaining of all these voiding symptoms and some pain. So I started reading as much as I could get my hands on to figure out what to do with these patients. And as you know, Dr. Terlecki had taught us about pelvic floor dysfunction. But I just needed more options because I was seeing so many of them. And I went back to Campbell's and I remember this vividly. There was one sentence in the CPPS chapter about pelvic floor dysfunction, one sentence. And that just left me with like, okay, what do I do? And then I just started reading and reading. And it felt a little bit like gaslighting because I was seeing it everywhere day after day. But it wasn't something at the time that we were talking about at all in the field. And it took me years from there to find someone to sort of mentor me and teach me what to do. So that is how I ended up I found a mentor in Dr. Ponteri at Temple, who Jay Raman, my chair, connected me with. And we were getting on the precipice of applying for some funding to do a study together. And that's when the open call for the guidelines went out. And that's how I applied and got on the guidelines panel.
Awesome. So throughout your career thus far, how has your management of these patients evolved?
It's evolved tremendously. In fact, I would say my diagnosis has evolved tremendously. So you know that joke as a medical student when they say, the surgeon can see as someone who needs an appendectomy from the door, or like the urology version, you can walk into a room and be like, yep, that's torsion. We need to go to the OR. It takes about 30 seconds. Chronic orchialgia is similar in that I wrote a paper in urology practice a couple years back, and a phenomenal medical student, Amy Zhang, who's now a resident, took all of our chronic orchialgia patients and grouped them into patients we had found pelvic floor dysfunction. So by, tenderness or pain on rectal exam, and those who just had sort of idiopathic chronic orchialgia. And although, slightly problematic in that we didn't use validated questionnaires because it was earlier in my practice and I pooled all these patients from my early practice days, we did do a good job of categorizing their symptoms at presentation. And the thing is, pelvic floor dysfunction presents as chronic orchialgia plus. So like if they have chronic orchialgia and voiding symptoms, like hesitancy, straining, weak stream, it's not a stricture and testicle pain. I mean, it could be, you got to get a uroflow. But if they have a clean scope or rug, it is pelvic floor dysfunction. So I think of it like an anatomical obstruction if it's a stricture versus a functional obstruction if it is chronic orchialgia, because they're just peeing through this really tight, closed sphincter. Feels the same.
Mhm.
So the other thing is bowel symptoms. They are like 6 times more likely to have bowel symptoms. If they have pain with ejaculation, that is almost pathognomonic. It is either a stricture or pelvic floor dysfunction. And if you don't diagnose the stricture, pelvic floor dysfunction. So chronic orchialgia, testicle pain, if you have bowel, bladder, or sexual symptoms, it's almost always pelvic floor dysfunction. And now that I know that, instead of going down neuropathic pain medications or, denervation, spermatic cord blocks, I just immediately ask those questions like a worksheet, like boom, 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 boom. And then, we start, I shotgun because they've usually seen a lot of providers before me. So I start with hot baths for relaxation, Flomax, maybe a trial of NSAIDs. And then I go ahead and put them in to see pelvic floor physical therapy if they are amenable, because it takes maybe a month or 2 to get them there. And usually these patients are a little impatient because they've been dealing with this for a long time. And as you know, problematically, not enough urologists and definitely not enough urologists seeing pain. So there's a book out. So they're usually, chomping at the bit to get some relief.
Yeah. Well, I certainly echo your sentiments about the value of the pelvic floor physical therapist. I literally, just before we're recording this podcast, I saw a patient. It was a 3.5-hour visit, and we were just talking about all the urologic maladies. And he was saying that he had a history of rectal pain with ejaculation. And it's like me standing at the doorway being like, I know exactly what's going on. And through the questioning, it just so turned out he had been doing self-directed Kegel exercises before that pain started, but he was treated with, like a month of antibiotics. And looking back, it's so obvious it's pelvic floor dysfunction. You can see it at the door.
Yeah. And I am a big proponent like you of evolution and pushing medicine forward, the use of video, the use of patient information so that they can have autonomy and be partners in their own care. But with the caveat that way back when I started on this sort of information or research arc, if you want to call it that, when people Googled pelvic floor dysfunction, my male patients, firstly, vaginas came up, all female patients. And secondly, Kegels. And I was like, no, please don't tighten your muscles. And so they would go home and they didn't want to go to the pelvic floor physical therapist, and they would learn how to Kegel from YouTube. Thankfully, there are some really great TikToks and there are some good YouTubes. And I actually pull up the QR code and say, here, go look at these videos. This is like the long form explanation. And yes, I think every urologist should be best friends with a pelvic floor physical therapist.
Or 5 of them.
Yeah, there's not enough of them. PSA, please, more pelvic floor physical therapists.
But you mentioned a really good point there is it sometimes does take time for our patients to get in to see a specialist, including pelvic floor physical therapy. So finding the great content online where PTs are explaining different techniques could be a great way so our patients aren't just twiddling their thumbs to learn information while they're waiting for their visit. I love that.
Absolutely. And I think, people like yourself, people like Rena Malik, other people who are putting out patient-facing materials, podcasts, and videos. I have not generally been that brave, although I'm getting braver. But that's really important because if it's not out there for patients to consume, they're going to consume misinformation. And we really want to curate what reaches the patients and combat the misinformation on the internet so that they don't think they have epididymitis and need, some more Cipro.
That's a really great point, Susan, because we oftentimes talk about misinformation online. We're not going to be able to get it off. So we just need to drown it out with our own content, which means we need to drown it out with our own content, and we got to put it to work. Yeah.
We need to content create. Yeah. As much as I hate to say it, I am anachronistically old. I live in an 1850s farmhouse. My children play with wooden blocks and we have a farm. I really like to do things the old school way in my personal life. But professionally, the digital revolution is here to stay. Gen Z grew up with iPads in their hands, and the way to reach people is through content creation, short digital bites where they can just absorb it, which is what today is about talking about chronic orchialgia and the guidelines so that our fellow urologists can, get those pearls, as you said.
Yeah. And we're going to make this talk on chronic orchialgia super sexy.
Okay. I'll leave that to you. That's not my specialty.
So let's talk about we were talking about content creation. Let's talk about guideline creation.
Yeah.
How did you get appointed to the guideline panel? What's that process?
I think it's evolved because I remember thinking it was so nebulous and wondering how people made guideline panels. And in the last couple years, I think the AUA has done a really wonderful push for inclusion. And so they've made guidelines open calls. And so you'll see if you go visit the AUA page regularly, on the front page, they do a really good job of saying like, open call for this guideline. So at the time when I was sort of I had just made associate and hitting my mid-career stride, looking around for like, what's next? I saw an open call for the OAB guidelines as well as the CPPS guidelines. I applied for both, mind you, although chronic orchialgia I was much more well-versed in. And I think just sort of like word of mouth helped, the fact that I had been working with Dr. Ponteri, who's a co-chair, Dr. Lai being the chair, is, aware of and friends with from residency training, I believe, my chairman, Dr. Rahman. And then Dr. Breyer at UCSF is also on that, and I had spoken to him about it. So before I even was appointed to the panel, I was talking to some people peripherally about it and my interest in it.
So what is it like to be on a guideline panel?
I'm not kidding when I say that it was the most intense period of lifelong learning and educational growth in my entire medical career. Medical school onward. Yeah, I signed on to it thinking I could make a difference for people. And what actually happened is it tremendously made a difference in my own education and my expertise and my abilities to be a good doctor. So, like without hesitation, if you can do this and participate in it, I would highly recommend it. It also takes back the curtain on like, as a resident, you think these are rules written in stone because you memorize the bold lines. But truthfully, they're evidence-guided, evidence-based medicine at its best. It is combing the available medical literature for all that exists and a group of people who have a variety of expertise within a particular area. And they come together and sort of duke it out in these meetings as to what's going to make the guidelines. It did get heated once or twice.
Oh, yeah? Tell me more.
I think, some people, everybody has an opinion on things and strong opinions. And sometimes there's opinions that the evidence doesn't always support. So there's no written thing that says don't give people repeated antibiotics. But of course, everyone on the panel was very, I don't want to say rabid, but we were really deeply concerned about the number of people just giving antibiotics and not getting better. It was a common story that we all see that anecdotally, we think do patients a disservice, which is why there's kind of 2 points that's addressed where it says like one trial of antibiotics for chronic orchialgia is okay. And also, a do not give repeated courses.
Mm-hmm. Oh, I would love to have been a fly on the wall during the duking it out process.
I usually was the moderator, as I have been in my personal life and family situations, etc. I was like, guys, your point is excellent and your point is excellent. Perhaps this would be a compromise.
Were there any surprises during the guideline process?
Yeah, there were. I think that I had no idea about shockwave lithotripsy for CPPS. And although the data primarily comes from other countries, which if you think about it, is going to be driven by insurance coverage and FDA approval in this country, which we lack. The data is fairly convincing. Although there were smaller trials, it was 8 trials, and they put it together in a meta-analysis, and nearly every different type of difference it could make in terms of, pain and sexual function, et cetera, it did make a difference. And interestingly, even though the shockwave was administered differently in some of the trials, like some did 6 different points in a grid on the perineum, some did focal where the patient pointed to pain, it still made a difference. And so I found that really surprising. And then I am going to suggest that you interview Dr. Larissa Bresler on acupuncture, who is part of our plenary panel discussing this. She is well-versed on it and could explain the whole background of acupuncture and the data behind it. I had considered that as a Western trained person, sort of like a peripheral adjunct or maybe a last resort, and have since really incorporated it into my practice. What can I say? I'm a convert. And I found out we have acupuncture at Penn State. After this guidelines panel, I looked it up and we had it the whole time and I didn't know.
Oh, I love that. And we're going to delve into, when I read the guidelines, there were a few that stuck out. So I want to delve into some of those. But when I was at the University of Iowa, I actually went to a nearby acupuncturist because I wanted to know, what is this all about? If I'm recommending to my patients, pin me, I want to know what this feels like. I couldn't tell if it worked because I wasn't having any concerns at the time, but why not start with the least invasive therapy? And I think there's so much value to conservative options like shockwave and acupuncture, and we'll definitely get into that a little bit more. So now I kind of want to go into these guidelines that really stuck out to me. And I want to get your opinion on some of these here. So the first one, as you alluded to, is the recommendations on the use of antibiotics. And you mentioned that was quite a heated topic. So one of the guidelines mentions that a single 10-day trial of antibiotics for antibiotic-naive patients with chronic scrotal content pain would be appropriate. How often do you see patients who are antibiotic naive?
Almost never.
Yeah.
No,
same with me.
Yeah. I mean, yeah. So I think that when patients are in pain, their first stop is going to be either an urgent care or emergency room, as we know, if it's a flare and they're in extremis, or if they're just, a lot of these patients are young men in their 20s to 40s and they don't have a PCP, so they use the urgent care system. Alternately, if they do have a primary care, that might be the first stop. And if they get in with a urologist, unfortunately, and part of the driving force behind why I took up this interest is that so few people want to see chronic orchialgia that it kind of gets relegated to APCs quite a bit because it's non-surgical. It's not necessarily RVU generating. So obviously I've made a really good career choice. Sarcastic, obviously. I say it's the thing we talk about with women, why they don't generate as many RVUs. But these are, I kind of jokingly say, give me your poor, give me your tired, huddled masses, as we say on the Statue of Liberty. It's my caring sensibilities. So they stop at people who are not necessarily well-versed in urology first. And when they say they have pain in their testicle, despite a negative urine culture, oftentimes, they will get treated with a course of antibiotics. And that's a very reasonable thing to do one time, I think, because you can't necessarily rule out chronic prostatitis, and I'm sure we're going to get into this, and a CPPS type syndrome from a negative urine culture. Mm-hmm. So I think it's a good first step. The issue is with the book out to see any urologist and or a particular urologist who sees chronic pain. I would say I'm the 3rd to 6th stop for most of these patients. So they've seen several providers before me. And that's also problematic because I'm having to back paddle. So they've consistently been told something like epididymal orchitis. And then I'm like, wait. And I tell them something that there's not much on the internet about. So it's hard to get their trust and to get them to try the things I suggest.
Yeah, I think it's challenging too because oftentimes their symptoms get better with antibiotics, even though it's not from an infectious cause and maybe more of an inflammatory cause.
Um, it's mixed. I have some patients who will get better temporary from antibiotics, but primarily my experience has been that they don't get better. And so that's in part how I gain their trust. When they think hot baths and ibuprofen, are you kidding me? I say, well, you tried 5 courses of antibiotics. Did they help?
Yeah, and their symptoms certainly came back. So, okay, how do we increase awareness amongst the providers that are providing, repeat antibiotic courses for our patients? Like, how do we get them to change practice? We know it's challenging to change the practice of healthcare providers.
Um, so that's I'm actually so there's 2 ways. We can address the providers. But you're talking about trying to change not just urology practice, which okay, we can do. I have dedicated myself to a lecture tour on chronic orchialgia and CPBS and the management thereof. So, any residency listening to it, I am available. So that I can reach all the trainees going out there and then slowly it'll percolate, right? But the other aspect I think we need to address rather than trying to reach all of emergency medicine and all of primary care is the patients, right? So most patients that I see, a lot of them, I would say, at least half, try to Google their diagnosis and figure it out for themselves on the internet. And I think if we, as you suggested, are good content creators and put out the basics of the information that is searchable and digestible at a patient level, then the patients can then find what they need and they will know when they're told, oh, it's epididymitis, that like, oh, no, it's probably, did you ever consider they can participate in their own care?
Mhm. I've actually been surprised when I look at the views that I have on some of my YouTube videos. The ones on testicular pain and pelvic pain are some of the most well-watched videos because I think people are so desperate for that information. I think sometimes we just have to make those topics like as sexy as do you want to blow a bigger, have like a big load, do Kegels. We just have to like have that punchline so people are like, do you want to get rid of your testicular pain? And then they watch it.
I think first they want to make their penis bigger, and then if they could also get rid of their testicular pain, they would.
Yeah, so some way we have to weave in those messages. I love it. All right, so the next guideline that I found interesting was on the vasovasostomy, vasectomy reversal for post-vasectomy pain syndrome. I find this a little bit challenging because a lot of my patients who I've seen for chronic scrotal content pain, at some point in their past, they've had a vasectomy. So like any pain after a vasectomy is technically post-vasectomy pain. How do you tease out whether their pain is from a vasectomy or just completely different?
Well, first, pretty much most of the things I say here, I have to disclose. Like, I'm not a representative of the AUA or the guidelines or the panel. So we're just talking about my own specific practice here. For me, I just use temporality. I also happen to do a large portion of vasectomies in my practice. So I've definitely surpassed 1,000. And I've caused post-vasectomy syndrome in probably at least 3 patients that I know of. And it happened immediately after. And their description of it was, I got my vasectomy. It was like a dull ache, and then it just never went away. And it revs with activity, and that activity is different for each person. Maybe it's sexual intercourse. Maybe it's like they're military and they run with their pack on, or like, heavy lifting, etc. But I think someone who has a vasectomy 20 years ago and then has a 2-year history of chronic pain, I'm not going to categorize as post-vasectomy pain syndrome.
Yeah, it's interesting because I feel like in all the notes that I've read from patients that I've seen from other providers, the temporality is never documented.
Huh. I don't know. Again, I think that's something, education. I think as we incorporate this into residency education, with this being part of the guidelines and, certainly board certification, that will become a trend where people will be more knowledgeable about that and hopefully document that.
Yeah. Well, I think the challenge too is oftentimes, as you mentioned, people are seeing multiple different providers. It's like a game of telephone. And oftentimes I think that message of temporality gets lost somewhere in that communication telephone mix.
It does. I always just start from scratch. I consider my visit with a patient almost like a second opinion every single time because they have seen other providers and just they are longer visits, though hopefully not, what was it, 3.5 hours? So my visits tend to be on the longer side, and I just try to go from scratch with like everything, like what makes it better, what makes it worse, like the basics, you know what I mean?
Mhm.
And if
So
it's
the guidelines mention that if a vasectomy reversal fails to relieve pain, then a targeted approach like a microscopic spermatic cord denervation would be appropriate. Like, in what scenarios might you do a vas reversal before spermatic cord denervation, or would you change like the order there?
so in my personal practice, I favor a denervation, and that probably has to do with my background. I assume you were 2 years after me in fellowship. I did several denervations in the fellowship, and if I'm honest with you, if I had just read the papers first and never done the denervations, I do not know that I would be such a fervent adopter. But having seen what it did for people and the way it made people in unlivable pain, pain-free, and how successful it was, when I went back and really did a deep dive on the literature and seeing success rates of 85% plus, I was a true believer because I'd already seen it in person in real life action. Um, Conversely, when I looked up vasovasostomy, because my patients, their mind process is, I had my vas deferens cut, my pain started. If you put it back together, my pain will go away. It's just that linear for them. When I think what we think about is, I explain, well, we cut the nociceptive C fibers, presumably in your perivasal sheath. And if we reconnect your vas deferens, it doesn't mean that those are going to heal back in a way that will resolve the neuropathic pain as we think about it. Um, Still, I think some of my patients are very set on that when they come in. So I have let patients, we go back and forth, but ultimately it is the patient's body and the patient's right to choose. So in my practice, if a patient pushes me, I will consider a vas reversal first. However, I think if they have good response to spermatic cord blocks in the setting of post-vasectomy pain syndrome, I would favor a denervation.
Yeah, I'm right with you on that one. Because then, then they're potentially fertile again, which they didn't want to be fertile. And I don't
Right.
find the spermatic cord denervation. I mean, it's a pretty simple procedure for those of us, who have done it and have that experience, and doesn't take, nearly as long as something like a vas reversal. So,
Yeah, it's like a souped up varicocelectomy. It just needs to be, demystified because everyone learns to do a varicocelectomy and it's really not that different a skill set. And I think also from an evidence-based medicine perspective, those vasovasostomy papers have roughly 30 patients in them, a couple of those papers, whereas denervation has been well studied in larger patient populations. So to me, just also in terms of the numbers and the robustness of the evidence, I favor a denervation from that perspective as well.
hmm So, also mentioned in the guidelines is doing testing to really tease out the NIH classification for CPPS. And so, how would you assess for, white blood cells? Because I've never done the test of getting like the, first voided stream, midstream, prostatic secretion, and post prostatic urinary test. I've never done it, never seen it. What do you?
Yeah.
That is,
So this is a problem where now you and I come from two different residencies, but we come from the same fellowship, and neither have I is the answer. Neither have I. So we really need like another chronic pain specialist in the room to argue with us on this one. But where the express prostatic secretions and the VB3, the voided urine afterwards come into play is ruling out chronic bacterial prostatitis, so that NIH class 2. Um, and they say in the guidelines, it says right there, if a patient has recurrent UTI and positive UTIs, you can get the sense with their history that they might be a type 2 patient. Whereas type 3 patients have like sort of a global pain syndrome. And then are there white cells and it's type 3 or versus no white cells, no inflammation, and it's 3A versus 3B. Then, I don't know that you necessarily have to do a 2 or 4 glass on that. I usually use symptoms to guide my treatments, and whether they're 3A or 3B, the treatment is fairly similar for me.
Yeah. And I liked how in the guidelines, it didn't say like you have to do this test. It said it's something to consider if you're not sure exactly what's going on. So I did like the verbiage related to that guideline.
Yeah, I think we're trying to leave as many diagnostic tools open as possible without mandating things that people consider esoteric. Because if you start asking people, like we're both two people who treat stress incontinence, when you try to actually do a pad weight, have a patient bring 24 hours of stinky pads in a Ziploc bag, it's wonderful for doing evidence-based medicine, but in real practice, not as pleasant.
Yeah, absolutely. Okay. So in the guidelines, it defines chronic scrotal content pain as unilateral testicular pain. Why was the distinction made for only classifying unilateral versus bilateral in the chronic scrotal content pain definition?
Okay, that's a great question, and I'm so glad you bring that up. So firstly, it's not necessarily hard and fast, in my opinion. And we debated this a lot, but if you're trying to take a mass of people who don't necessarily want to engage or deal with these patients and break it down to like an algorithmic diagnosis tree and treatment, so you want to make it easily adoptable, then simplifying your definitions is easier. So again, when I looked at my chronic orchialgia population, the patients who had radiation of pain were much more likely to be a CPPS type picture. That's not to say you couldn't have isolated bilateral chronic orchialgia. You can, but more often you have bilateral chronic orchialgia plus voiding symptoms or bowel dysfunction in their pelvic floor, or bilateral chronic orchialgia plus suprapubic and perineal pain, in which case they're more like a CPPS. So the reason we kept it to chronic unilateral orchialgia is because the isolated pain to the testicle is more common with its unilateral. It's not meant to be exclusionary. It's meant to help people diagnose.
Yeah, that makes sense. It's, I think about our patients and they are as simple or as complex as we allow them to be, right? Oftentimes these patients come in and like on the little note section by like the scheduler, it says right testicular pain. But when we ask our patients question for the real sake of understanding their scenario, they have a lot of other symptoms going on typically. It is rarely the isolated right testicular pain with no other symptoms.
Correct.
So let's talk about the guideline that talks about screening for neurologic, musculoskeletal, and orthopedic abnormalities. I always thought that this is one of the most challenging pieces. It's like, the guidelines, really in every guideline say take a, big comprehensive history and then rule out all these other things. But the guidelines don't tell us how do we rule out hip pathology, orthopedic injuries, right? How do we know when to refer someone to a specialist? So, how do you tease that guideline out?
I was actually going to tell you, didn't you write the paper about the MRIs? Wasn't that you?
Because I'm trying to figure this out.
Yeah. So I reference that paper in my lectures all the time. So, all right, I think we need to simplify it, right? Like I've said over and over and over. Firstly, obviously, I think you should do a good neuro exam. In theory, you should do a full neuro exam. But again, chronic pain patients take up quite a bit of your time. And so I ask a simple question like tingling fingers and toes. I ask what they do to assess like how much impact on their body, their spine, etc. I think a key one that is a substitute for hip is, can you do stairs? Because I think you use a lot of your muscles and your hip joint to go upstairs. And if stairs triggers pain, I'm always thinking about their hips. I don't do the hip abduction. I don't move their legs around, etc. I do a genital exam and then some sense of a neuro exam to see what their sensation is around different points in their body and their strength in their hands. And that's what I keep to predominantly, unless I think there's a spinal issue or a hip issue, in which case I might do more of a deep dive. And as for imaging, I usually refer. I used to try and order the imaging first, but I don't, we're not trained in that. And that's your whole point in asking this. Like, we're not trained in this, right? So that's where you need to have a friend in orthopedics and a friend in neurosurgery spine. And they are the person you siphon these referrals to. They're not going to come along super often, but they are there. I had a patient who had chronic hip pain and he had a TENS, and he used to just moderate it with his TENS. And he also had testicle pain. And when he resolved his hip pain with his TENS, his testicle pain got better. Underwent total hip arthroplasty, pain-free, both hip and testicle.
I saw a guy like that too. Now, the reality is it's not, most of our patients are not going to benefit from having their hip replaced, right? But it's finding like that 1 in, 30, 1 in 50, where that's the underlying issue. What I've also learned over the years is it's not enough to ask someone, do you have hip pain? It's not enough to grab their hip, shake it back and forth and say, does that cause you pain? It's not enough to just push along their spine and say, do you have any point tenderness? It's using questions that are in some of the orthopedic questionnaires, like, does it hurt when you tie your shoelace? Like, we were never taught to, ask that question. Does it hurt getting in and out of a car when they're doing certain things with their hips, with movements? And so I've learned a lot from my orthopedic colleagues, my pelvic physical therapy colleagues. I do those hip provocative test maneuvers, but then it's this constant conversation with the pelvic physical therapist where I'm like, hey, can you see if his hip, might be involved? So sometimes it might not be sending the patient to an orthopedic surgeon. It could be working with the pelvic physical therapist who's also already seeing that patient to see if they think there's, a hip or back issue involved. And then when it comes to the back, I usually order a lumbar MRI. And I actually send the MRI, the images, to a colleague of mine in San Diego, Dr. Chol Kim, because he's like the only spine surgeon I know who has expertise in pelvic pain as it relates to the back. And he looks at the images and then gives me guidance on what to tell my patient. So he's the guy that I have in my back pocket that allows me not to waste anyone's time, but to provide my patient with some of that information. We just got a paper published looking at using all these different questionnaires in other specialties, including the ones in urology, but also the WHO's, which is used in orthopedics for hip issues, the Oswestry back questionnaire. So we're trying to figure out what are those relevant questions in the other specialties, and how do we not overwhelm our patients with all these questionnaires? What are the necessary questions? Still definitely a work in progress.
Yeah, that would be so great if you could boil it down to like 3 or 4 really simple questions.
Mm-hmm.
The other thing I would say is someone who is both a doctor and a patient now, and this comes up with my patients all the time too. You have a symptom and you don't know what that means. You don't know what organ system it relates to or what it's pathognomonic for when you're a patient. So if you have pain going upstairs, you don't know that that's necessarily your hip. You just know that this one move triggers that. And so patients don't necessarily know to volunteer that information. And we always get the 2 sides of the coin, right? You get the patients you have to drag it out of. You really have to ask them all those questions. And equally, I get patients who just tell me everything. And some of it's extraneous and it actually gets distracting. But what they're really trying to do is make sure that they tell you that it hurts when they go up and downstairs so that you can think about their hip.
Mm-hmm. So also in the guidelines are interesting therapies, which I've actually never seen as considerations in any of the other guidelines. So one was a mention of the role of acupuncture, and others were the mention of different supplements. So where did these play a role, if any, in your practice? And I know you mentioned acupuncture, that now you do recommend acupuncture.
Yeah, I do. So I think, the data for acupuncture is pretty strong. And I think that we should be availing of ourselves of all modalities. And as you mentioned, fairly non-invasive as things go. It's not surgical. Some of the neuropathic drugs are good, but they have quite a bit of side effects. So if, I'm a working 30-year-old and I need not to have brain fog, then maybe acupuncture every so often is a more appealing alternative. So that's one thought. And then the phytotherapeutics was also something in there where I have started recommending those. And outside the ones mentioned in the guidelines, I've actually had several patients tell me freeze-dried aloe vera was helpful to them. And I'm willing to consider, as long as, the patients know that these aren't FDA regulated, firstly. So what you're actually getting in these capsules could be variable. Um, and then, understand that even the phytotherapeutic studies that showed a difference, it's small sample sizes, So I will recommend quercetin or Cernilitin, the pollen extract. If patients have considered sort of what I consider first-line therapies, which is more like maybe a spermatic cord block, or I also use Cymbalta off-label quite a bit, in addition to gabapentin and Lyrica. Um, it's really up to the patient, and as long as they understand small studies and limited evidence.
Mm-hmm. Yeah, I love that phytotherapy showed up in the guidelines, because if we think about the side effects compared to maybe some of those therapies versus, as you mentioned, the neuropathic pain medications, I mean, we got to compare these, right? And I agree with you. I mean, I'm limited in terms of using medications like gabapentin in my men who are 20 and 30 years old. Whether or not it's like super efficacious or not, the side effect profile is going to drive my management. So I think the key things, for people watching when it comes to the phytotherapies is we have to make sure our patients are getting quality phytotherapies. And I think that's where it's on us to recommend, hey, get a product. Maybe we do our own research. These are the good companies. These are the ones that do third-party testing, right? So I think we as urologists have to really take it on ourselves to say, hey, phytotherapies might play a role in this condition. How do I direct my patients to the good products so they're not guessing?
Yeah. I think when you find a good one, it is nice to recommend. So I am newly aware of this, having been on the guidelines panel, and don't have a particular brand that I've looked into. I usually just write the name down for the patients and let them do their own shopping. But like, for instance, when we talk about female partners and lubricants, I have some lubricants that I have personally tried out on my hand at the AUA, met the reps, etc., and thought, okay, that's good. Accidentally, I'm not going to name the company because I know we shouldn't, but I went up to someone, they put lube on my hand, and oh my gosh, staying power. What
was the company? Shared it. You want to know. Audience wants to know. So he was thinking,
okay, all right, fine. It was Uber Lube, but my hand was shiny for 45 minutes walking around in my suit. And even when I tried to wash it off, it was difficult. So now I will tell my patients, I'm like, go get some Uber Lube. That's some good stuff.
Yeah, I think it's one of the most helpful things we can do for our patients is to help navigate the overwhelmingness that is supplements and OTC therapies.
Yeah, and also, I mean, supplements and OTC therapies goes hand in hand with misinformation on the Infomet, because there's a financial incentive for them to sell you their supplement.
Yep. So what practical tips would you offer clinicians when it comes to incorporating these guidelines into their everyday practices?
I would say, firstly, you need to be doing a rectal exam when patients have scrotal pain. And I know that just absolutely blows people's mind, but there is a really good diagram in the guidelines that shows the different points with numbers where you're going to press. So we all know this is the prostate. But then if you swing your fingers lateral, you're going to hit your anterior levators, and then farther lateral, you're going to hit your obturator internus, and then the posterior levators. And if you press on those muscle struts and the patient goes, ow, that's pelvic floor dysfunction. And rather than, so we recently did some trinetics work at my residency, and people are still doing orchiectomies at about double the rate of denervations, for instance. And I always say, we don't chop off fingers and toes of diabetics because they have neuropathic pain. So I think you should identify pelvic floor dysfunction where you can, because that's very treatable with your pelvic floor physical therapist, muscle relaxants, suppositories, stress relief, multimodal, using cognitive behavioral therapy, stress management, all of it, right? You can, in a much more less invasive way, take care of a patient's pain and treat it long-term without invasive maneuvers or side effects. The other thing I would say is, there are a lot of options. So if you just, these pain patients won't be so frustrating if you have something to offer them, right? I think part of what frustrates the average provider is feeling like, what do I do? Or the fact that they come in with 7 symptoms. But when they come in with 7 symptoms, again, Occam's razor, it's underlying pelvic floor dysfunction, or it's a chronic pain syndrome. So they have like pervasive pain. And again, you need to think about their pain holistically is how you can treat it. So those would be my 2 tips. The other thing I would say is some of these patients are cagey, and understandably so. They've been waiting months to years. They've seen lots of people who in their eyes are equivalently expert. They do not differentiate between NP, urgent care PA, ER doctor, specialty urologist, like whatever. They're all providers, and they've all been told different things. And it's very, 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 very confusing and frustrating for the patient. So when they come into your office skeptical and jaded, don't take offense to that. You know, I consider that a personal challenge. Okay, you've thrown down the gauntlet. Let me try to win you over and win your trust. And one of the ways to do that is listen. Really take the time and effort to listen. Repeat back their symptoms to be clear that you are recording their symptoms as opposed to like your perception of their symptoms. Don't just shove them in a box. Write down what is actually happening. Repeat it back to them. Validate that their pain is real. And this is in the guidelines. It is not in their head. They have been told it's in their head. And the reason they get told it's in their head is because I think people don't explain the way stress exacerbates psychosomatic pain. Like, I explain to people that from the time I was young, I had a tachyarrhythmia long before I could say tachyarrhythmia. And it was very sporadic. And then it started happening very regularly in residency. Like, I would be in clinic as a chief and I'd put my finger in the little pulse ox and my pulse was like 160 and irregular. So I got a Holter and all of that stuff. And you know what they said? Stress and caffeine induced. And sure enough, my first year as an attending, it went away. I didn't have it. And then I had to study for the board. And every single day I had tachyarrhythmia. And the people around me were like, whoa, you're so cool as a cucumber studying for the boards. And I said, my body begs to differ. My body's probably pumped full of cortisol and my heart really knows what's up. So everyone has a different like somatic manifestation of stress, whether that's headaches, or we talk about like knots in the trapezius muscles, neck tension, and some people carry it in their pelvic floor. So I think validating that their somatic symptoms are real, it's not in your head, but stress worsens it. And then offering them options and partnering with them to choose those options. Some people want a definitive fix. They want to go towards surgery. And some people want to do medications or less invasive things. Some people want something left field, like they consider phytotherapeutics or acupuncture potentially left field. Some people want something more standardized, you know? I think you have to listen to the patients and pair with them to direct their therapy.
Yeah, that's a beautiful message. And I think one of the beautiful pieces, I think, of this guideline is that there are so many options. So it's rare that there's nothing we can offer our patients. I know, like in the pain management literature, Tai Chi is an option. So if the person's like, is there anything you have left? It's like, have you ever tried Tai Chi?
Yeah.
There's always something, right? Well, Dr. MacDonald, thank you so much for sharing your expertise today. I really loved how we delved into what the guidelines said, but also how you incorporate those guidelines into your practice and how you kind of, I don't know, finagle with them. And sometimes you do what's in the guidelines and sometimes you don't. And that's reality. That's what practical medicine is. That is the art of what we do in medicine. So I appreciate you sharing your expertise. You had mentioned before we hit record that you were going to be starting your own YouTube channel. So please talk to us about what your mission is with your YouTube channel.
My mission with my YouTube channel is actually not about chronic pain. So there's a couple of personal interests I take within urology. And one of them, as you know, is surgical education as a program director. So as a hobby farm owner, and I promise I will get back to the YouTube channel, I came from Manhattan and previously Atlanta and then Jacksonville. So cities of 1 million to 4 million to 8 million. Had never owned a farm and then moved to Hershey, PA and started a farm. And it was very like Green Acres. I had no idea what I was doing. It could have been a really great sitcom. And I learned everything I know from YouTube. And now I am a semi-crunchy expert on all things heirloom vegetable and flowers. I say semi because there are people who know far more than me as a part-time farmer. And then I got to thinking, I wrote a paper with one of my residents about how people prepare for the OR, because I noticed people were reading Campbell's less and looking at the surgical atlas less and using YouTube more. And we showed that 93% of urologic residents quote YouTube as one of their top 3 sources, regardless of print or video. Like, it's one of their top 3. And at the time I was just thinking, like, okay, like, how do you prepare for surgery in this day and age? And clearly there's been a shift with high def streaming and widely available Wi-Fi and smartphones, etc. And then once I did that, someone asked me to give a lecture on teaching Gen Z. And I thought about that, and I thought about how they've been learning from video from the get-go. And then I thought about everything I learned on my farm and how I had learned from video. Not just them, me too. And then I thought, oh my gosh. So the other thing I see now is when I am teaching in the OR and medical students come in, there are just basic things like knot tying, for instance. We do knot tying, and the knot tying happens in these little suture workshops. I don't know how it's done. It was done at Iowa, but like, they'll ask for a couple of volunteers and they'll do it at night. And I thought, why are we taking medical students and very busy surgeons and at 6 p.m., like prime time when they could be eating, having them learn to tie knots? Why don't we do this asynchronously at the comfort of your home, wearing your pajamas? You could be tying knots and learning to do it. So my YouTube channel is called Surgical Basics, and that's literally what it is. It's like how to learn the basics of operating outside the OR asynchronously. And the joke I say is, those who can't do teach. Now that I am part-time, I'm going to devote more of my efforts to content creation to accelerate other people's learning curve.
Oh, I absolutely love that. You're really paying it forward. And we're so impressionable as medical students, and we're so hungry for easily digestible information that I think that's so key. So where can people find more about your practice and what you're doing on YouTube?
Oh, that is an excellent question. I guess you could go to Surgical Basics on YouTube. I also have Twitter, @MacDonald_MD on Twitter, so you could see what Penn State Urology is up to, where I'm speaking. I love to travel, and I also am deeply passionate about chronic orchialgia. So I am doing several grand rounds or visiting professorships this year, in which case I will be disseminating this information about chronic orchialgia and use of video to enhance surgical education as well as patient education.
Awesome. Dr. MacDonald, thank you so much for joining us today on Pearls and Perspectives.
Dr. Pearlman, thank you so much for your enthusiasm for chronic orchialgia. Something very few people can muster that kind of enthusiasm for.